So keep in mind that as we do research with small n's, like 1, we are in a position to have great experimental control, right? As an example, in the studies with HM, these memory tests that they performed on him are very well designed to isolate memory components, right? Furthermore, to study HM's performance, we're in the position where we can very carefully select the right control group. Right? We can match on age and experience and so forth, which is indeed what researchers have done. So experimental control, manipulation of stimulus materials and experimental tasks, replication is very simple, right? These are all very well under the control of the researchers. Very often, but not always, as I mentioned, we study special cases when we do small n designs. After all, there are not a whole lot of people like HM. Only relatively few people have suffered damage to the hippocampus on both sides of the brain. After HM, that was of course no longer done surgically, but some people have lost the hippocampus on both sides of their brain because of, for instance, a viral infection. Of course, small n studies do suffer from disadvantages. Consider, for instance, again, the repeated studying of HM. HM turns out didn't just suffer damage to the hippocampus, but also to a lot of the surrounding regions, including the amygdala. Also, because of the medication, over time, he suffered also damage a little bit to his cerebellum, right? That multiple regions of damage make it difficult to accurately pinpoint which damage caused his symptoms, right? And so that is an internal validity issue. Of course, we can compare across patients like that and also take other lines of evidence into account, like neuroimaging and animal studies and so on. Right? We look at parsimony, at the lot of evidence, the bulk of the evidence. Another disadvantage, which is one I already mentioned, is of course the external validity. Right? When we have only a few or just one participant in our study, we can't be certain whether this individual reflects the population at large. Example, to stick with HM, HM had a history of very extreme epilepsy, right? That makes him a unique individual in and of itself. Right? Does that mean that we can generalize findings from him to the population? Again, importantly here, we don't just rely on one single study or one single individual, but we take evidence from a lot of sources into account. Anyway, obviously, studying people with brain damage is only one example of a small n design. We can also study small n designs in other settings, right? In educational settings, in clinical settings, in work settings, psychologists have done studies with small n designs to study whether an intervention works. So let's say we're an occupational therapist and we try to improve a client's behavior. Right? Let's say that we teach an Alzheimer's patient a new memory strategy and then observe if that improves the patient's memory. Or maybe we're a therapist working with an autistic child and we want to see whether an intervention helps the child deals with certain things. Perhaps we're a therapist working with a developmentally disabled adult and we try to introduce some manipulation to try to get this adult to stop self-harming behavior. Right? In each of these cases, in these applied settings, we have an intervention and we want to know whether our intervention works. And when we do see a change in behavior, we want to ascertain that it's our intervention that caused the change in behavior and not something else. Notice that that's an internal validity question, right? Making sure that it's our intervention and not something else that caused the change in behavior. So we have several study designs that can be used, and one is what's called the stable baseline design. Again, imagine that we're an occupational therapist working with an Alzheimer's patient, and we are teaching them a new memory technique. In our case, let's say that we test their memory for in a memory test for words, and we test the percentage of words recalled. Then we teach them the technique, and we continue to measure the amount of words recalled. Right? Let's say that this is our data, and it's actually real data from an actual Alzheimer's patient who was taught a new memory technique at this point in time. Each of these is a 2-week interval. So we have a memory test every 2 weeks. So obviously we want to know whether this dramatic improvement in this patient's performance on these memory tests is because of this intervention or because of something else. Well, one of the things that we can take into account is what's called the stable baseline, right? We measured not just once, but we have 5 measures that provide a baseline measure, and we observe that the patient's performance is relatively stable during these 5 baseline measures. Right? So the logic here is a stable baseline. The logic of the stable baseline design is that we first measure a relatively stable baseline, then introduce a manipulation, and if we then observe a change, then we can, because of the stable baseline, conclude that it's likely our intervention here. Of course, we're not 100% certain. It could be something else that took place around this time, but the stable baseline makes it unlikely. Right? Obviously, we only want to make sure that we change only one thing at a time. We change only one thing at a time, so we can isolate that. Note also that we don't just have one measurement afterwards, but we have several measurements afterwards, right? And these measurements combined may convince you that it was indeed the memory strategy that is responsible for this sudden increase in performance. And again, another thing to take into account is replication, right? If we see the same pattern in multiple studies, again, studies each one using just one patient, then we can be convinced that this intervention is responsible for the increase in performance. And this has indeed been shown. Right, so that is also something that we can take into account when considering the internal validity of these designs. Which brings us to the multiple baseline designs. In multiple baseline designs, we use again a small n, just a limited amount of people, and we introduce the manipulation at different times for each individual. Consider this study here, which used 3 autistic children, each of which was afraid of dogs. Okay, that's quite common in autistic children. So in this study, each child every day was brought into a gym where there was a therapy dog, and the child was just told to get as close to the dog as they dared on every day, and it was measured, here's the distance from the dog in feet, how close they dared to go. Then a training was introduced called contact desensitization plus reinforcement training. And this was introduced for each child at a different point in time. So for Jan, it was introduced at this time. For Sally, it was introduced at this time. And for Bob, it was introduced at this time. Those are obviously not their real names. Okay, so you see a improvement in how close they got to the dog, pretty much right after the introduction of this training program for each child, right? So since the training program was introduced at a different time for each child, yet the improvement was observed for each child more or less immediately after the introduction of the training program. For this kid after a couple of days, but for the other two kids more or less immediately. Right, we can be relatively certain that it's the training program and not some external event that caused the improvement in these kids' behavior. So this, when we have multiple single subjects, multiple single subjects sounds like a contradiction in terms, right? But when we have relatively few studies and we observe a baseline, a stable baseline for each of them, and then we introduce a manipulation for each subject at a different time, we call that a multiple baseline design. There are of course variants, right? In other studies, a multiple baseline could be represented by different situations, where we have the kids, for instance, in different situations, or we could test different behaviors. That could be another form of multiple baseline design. But the logic here is the same, right? With a multiple baseline design, it makes it really unlikely that the change in behavior is due to some other external event, right? And it's most likely that the change in behavior is because of our intervention. Yet another approach we can take is what's called a reversal designs. Right? A reversal design. In a reversal design, we can apply a treatment and take it away again. So we have a baseline phase, a treatment phase, and then we take the treatment away and we observe during yet another baseline phase, and then apply the treatment again, and we could go back and forth a few times. If the symptoms or our target behavior varies reliably between baseline phase and treatment phase, then we can be fairly certain that it's the treatment that is responsible for the change in behavior. So in this example here, we have an autistic man with a predisposition of rumination, barfing up food, which according to the textbook was a severe case. So he had been hospitalized for weight loss. And so they had a baseline phase where he was simply observed and a treatment phase where he was both presented with food and with attention. Right, so here was his rumination response per minute during baseline phase, during treatment phase, during baseline phase, during treatment phase, during baseline phase, during treatment phase. And you can see that his rumination behavior during the treatment phases in blue is reliably considerably lower than that behavior in green during the baseline phases. Right? So we can be certain that it's the treatment that is responsible for this reduced behavior rather than some other factor. It's really unlikely that some other factor happens to coincide with with these treatment periods. Right? Now, obviously, not all behaviors lend themselves to a reversal design. So, for instance, right, if we teach someone a skill, we can only have one baseline phase because we can't unlearn the skill. We can, right? So not all behaviors lend themselves to a reversal design. But in situations where a treatment or an intervention doesn't cause permanent changes in behavior, we can apply a reversal design, which makes it extra convincing that it's a treatment rather than something else that's responsible for the change in behavior. Keep in mind, yet another reason why a reversal design may not always work is because it may violate ethics. Right? If something works, in some cases it may violate ethics to withdraw the treatment. Right? Not perhaps in this case, but in other cases, yes.